Yeah, everybody is fine.
Thank you so
With
much.
the grace of God, everybody is fine.
So we are starting now. First of all, I will introduce Dr. Shiva Kumar. Is my screen is visible?
Yes.
Okay, thank you. So our today's lecture, our faculty of the day is Kothandam Shiva Kumar. He is MD,
Right.
DCH,
Full screen,
DNB.
please. Full screen, please.
What? Oh, full screen.
Yeah.
Yes, I am not getting here the icon of the full screen.
নিচে ম্যাডাম 77% পাশে যে আইকনটা ক্লিক করুন ম্যাডাম নিচে নিচে
হ্যাঁ কি করব?
77% লেখা না ম্যাডাম তার পাশের যে আইকনটা ক্লিক করলেই হবে
কোথায় 77%?
নিচে নিচে জুম করার যে পাশে যে আইকনটা বা কিবোর্ড থেকে F5 প্রেস করুন ম্যাডাম F5 কিবোর্ডের F5
F5
জি
হচ্ছে না কেন? 77%টা কোথায় আমি তো দেখতে পাচ্ছি না এটা।
স্লাইডের নিচে ম্যাডাম এর পাশে যে স্ক্রিনটা ফুল স্ক্রিনের বাটনটা ক্লিক করুন
ম্যাডাম বটম লাইনে একেবারে রাইটে কাপের মতো আছে
হ্যাঁ ওইটাই তো আসছে না আই ক্যান্ট সি দ্যাট
ম্যাডাম ওই যে
ম্যাডাম প্রেস F5
লেফট সাইডে না একদম ওই যে জুমের নিচে একদম যে জুম কমানো বাড়ানো যায় যে সেখানে
আচ্ছা জুমের কাছে I don't know, it's not coming, the full screen option.
ম্যাডাম প্রথম দেন স্লাইড শো তে ক্লিক করুন স্লাইড শো টপ মেনু বার
Okay, I got that one.
yes yes yes
Yes.
yeah, right it's back slide
Okay, okay. Okay, welcome you all to our today's lecture session. Our today's faculty is Dr. Kothandam Shiva Kumar, who is the head of the Department of Pediatric Cardiology, Senior Consultant, Institute of Cardiovascular Disease, Madras Medical Mission. He was graduated in 1990 from Coimbatore Medical College, India, and he had postdoctoral training in DCH or Diploma in Child Health, MD Pediatrics and DM Cardiology in 1994, 95 and 1999. He had medical license from various states of India along with United Kingdom and Sri Lanka. He qualified medical board certification from National Board of Pediatrics and National Board Cardiology. And he is the member of many professional societies, almost all the cardiology related societies of India. And his professional experience, currently he is the head of the Department of Pediatric Cardiology in Institute of Cardiovascular Disease, Madras Medical Mission since May 2013. But before that, he was the chief pediatric cardiologist of MIOT Hospital, Chennai, consultant pediatric cardiologist, Apollo Hospital, Colombo, specialist pediatric cardiologist in Amrita Institute of Medical Science, clinical observer in Boston's Children's Hospital, and fellow in cardiology in Sri Chitra Institute for Medical Science. He has many publications. He he wrote 23 chapters in many textbooks and about 122 index publication in national and international journal he has. And he also has many awards, distinction and honors. Among them, important are Professor Rajendra Tandon Memorial Gold Medal Award, Cardiology Society of India, then Dr. Reddy Gold Medal Award, Young Investigator Award and Medal, and then many other awards which you were seeing in this page. So with this, I would like to request Dr. Shiva Kumar to start his very important lectures on stenting in congenital heart diseases. Dr. Shiva Kumar.
Dr. Shiva, please unmute yourself.
Unmute Dr. Shiva.
Can you hear me, madam?
Yes, please.
And can you see my slide?
Yes, everything is fine.
Okay, I was telling that apart from this COVID pandemic, otherwise I had been visiting Dhaka almost 2 times every year and have taken a lot of pleasure in interacting with all of you senior members in the Pediatric Cardiac Society of Bangladesh. So it's a pleasure to again see you all virtually. The topic of the day, stents in pediatric cardiology and congenital heart disease. First question is, why do we need a stent? We will have to relieve some stenotic lesions. Sometimes if we balloon dilate and if there is a dissection or a tear of the vessel wall, we may have to support that weakened vessel wall. If we dilate and if we anticipate that the vessel is going to have an elastic recoil slowly over the next few weeks or months, then we need a stent to prevent a recoil. If there is a vessel with an aneurysm, we may have to exclude it. And if there is a patency of a pre-existent communication, like for example, a ductus arteriosus which has stenosed, and now you want to open it out and maintain its patency, you may have to stent it and ensure the patency of a newly created communication. For example, in atrial septum, you have created a hole and you want the hole to remain permanently open, then you may need a stent. I'll take these 6 points and just illustrate one example. First, relieve stenosis. I'll show an extreme example. A 6-year-old Takayasu's disease with middle aortic syndrome, severe middle aortic obstruction. You can see the heart so large, the cardiac contractility is so poor. Obviously, there is severe LV dysfunction, a tight middle aortic obstruction, and down if you push the catheter, there is a tight infrarenal abdominal aortic occlusion. And if we have to relieve both these obstruction, balloon dilatation is not going to be of any use at all. And so obviously, this is the stent angioplasty, the stenting of the middle aortic region and stenting of the infrarenal abdominal aorta. This is the 3D rendered picture. This is what is the utility of a stent. So it is to relieve stenosis. Number 2, it is to tag a dissection. Sometimes we can achieve a relief of stenosis by balloon dilatation itself. Let's see here. This is a small CP stent that has been placed on a coaptation. You can see the shelf here. So a discrete small stent is being opened. And after you open up the stent, you are able to see that there is a vessel wall tear. There is a tear extending on the inferior surface of both the sides. Here also there is a tear. You are able to see the extravasation. So in such a case, you may have to use a covered stent. So this is a long covered stent that is implanted in order to tag all the dissections. And this is the final picture wherein we have completely tagged the dissection and strengthened the vessel wall. So this is reason number 2. Reason number 3 is to prevent an elastic recoil. So this is a sort of near atretic coaptation. If we are able to pass a guide wire through and pass a balloon, we may be able to stretch the balloon to some extent. But the moment we take out the balloon, it's going to completely recoil because this is an extremely severe form of stenosis. There is hardly a lumen here. So in such a case, you may have to use a stent in order to prevent the recoil of that lesion. So this is a covered CP stent that is being deployed, and finally the lesion is prevented from recoiling. It is also used to exclude a vessel wall aneurysm. So what sort of aneurysms? I said this is a coarctation with a ductal aneurysm here. So there is an ampulla, the duct is still flowing, a little bit of flow is there, and there is a ductal aneurysm. You want to close off this aneurysm also. So now you have put in a covered stent here, and the covered stent has totally taken away the ductal aneurysm. The same thing, if it is a larger PDA, so it's a tight coarctation with a large PDA. This is a rotational angiography, and in the rotational angiography we are finding a tight coarctation and a large PDA. The PDA is almost filling the cup. So if you have to do both at the same sitting, so this is a covered stent that has been implanted, and this covered stent is both excluding the PDA as well as relieving the coarctation. Ensure the patency of a newly created communication. So this is a Glenn shunt that is being done. Second postoperative day, the surgeon does a pericardial patch plasty of the left pulmonary artery and does a Glenn. So that the entire pericardial patch plasty has collapsed and has closed off. So now you are pushing in a wire through the pericardial patch repaired pathway, but you will not be able to maintain it open. So now this newly created communication has to be maintained open by a stent, because this anterior aorta will be pressing on that newly created pericardial patch. See the aorta is coming here. Will be pressing on the newly created left pulmonary artery, and it will be pressing it out. So you may need a stent. Ensure the patency of a recently created communication. This is a Fontan pathway. A Fontan has been done a few years before. An extracardiac conduit has been placed. But because of lack of anticoagulation and lack of platelets, it has chronically thrombosed off. The entire Fontan conduit has chronically thrombosed off. So in the long-standing thrombotic occlusion of this Fontan pathway, if you are able to recanalize it, this is a broken burrow needle which is burrowing the way through, and you reach the upper end, and then finally you get a patency. But this patency has to be maintained. You may have to need a stent. So this is a stent that has been placed to retain the patency of the newly created communication. So these are in general the principles of coarctation. Where are the potential utilities of stents? Branch pulmonary arteries, systemic and pulmonary veins, either SVC or IVC or pulmonary vein, aorta and its branches, right ventricular outflow tract as well as right ventricular outflow tract conduits, both native RVOT and conduits, ductus arteriosus, very rarely in obstructed TAPVCs, ductus venosus, aortopulmonary collaterals may need to be stented, surgical shunts, BT shunt that is occluded may have to be shunted, venous conduits may have to be stented. Intracardiac communication. Sometimes if you create an atrial septal defect, that may have to be stented to maintain it open. Fontan fenestration. So various places where stents may have to be used. In general, the material that are used, most of the stents are metallic. Originally, the first stent to be made was a 316L stainless steel. If you remember, way back in the late 80s and all, the stent that was used was Parma stent, which is a stainless steel stent. And even now, Parma's, Genesis, Formula, Value are all stainless steel stents. Platinum iridium is CP stent. The recent stents are all cobalt chromium, because cobalt chromium has got a much higher radial stress, and the examples are Andra, Zephyr, etc. Nowadays, in the last about 10 years, there are a lot of polymeric stents, polyl lactic acid, polyl glycolic acid. These are called absorb stents, which are absorbable stents. Similarly, magnesium stent, biocorrodable iron stents, all these three later ones are absorbable stents. Why do we need an absorbable stent? If you have an absorbable stent in a small child, it will allow growth. So you can go and put a 8mm stent in a small young infant, and by the time the child grows into around 2 years, the stent would have been absorbed. So it will just act like a temporary scaffold. It will allow the local vascular compliance to recover. It will not restrict further surgery. It will have sufficient radial strength to prevent a recoil. It will have minimal thrombotic and inflammatory response. It will avoid intimal ingrowth if you have drugs like sirolimus eluting through that, and it will reabsorb within months to years. There are no toxins and no embolic material, and easy processing and easy sterilization. I'll show one example. A preterm baby, 600 grams from Calcutta. Severe pulmonary vein stenosis, chronic lung disease, 6-month-old. The child grew up to about 1 kilogram. The child was continuously oxygen dependent all these 6 months. The basic problem is severe pulmonary vein stenosis. There is a left pulmonary vein stenosis, upper and lower. So now, in a small baby, by the time this intervention is being done, the child is 1.2 kilogram. In this small baby, if we have to get this child out of the oxygen and get the child out of the hospital, we may have to do something. And if we are going to be putting a metal stent, it's going to be bad. So what we are doing here, this is a catheter that is entering inside. Can you see a dot here? This is actually a stent. If you faintly see, there are platinum dots here and platinum dots here. So basically what we have done is we have stented the upper and the lower pulmonary vein. This is the upper pulmonary vein and this is the lower pulmonary vein, which resulted in improvement. So there are some selective indications for a biovascular scaffold, but unfortunately the science is still developing. We don't have commercially available biovascular scaffolds to be used in small babies. Multiple research work is going on, and this is also one of the research work. This is actually a polyl lactic acid bioabsorbable stent that we used 5 millimeter in a small newborn baby. It is all yet to come to clinical practice on a routine manner. So in the first part of the talk, what we see was why stent is needed and what are the types of stent. Now we will go into specific locations. So this is going to be the second part. Now, obviously, it is not going to be possible to cover everything. I am sure many of you would have seen many stent angioplasties. So I am going to take up some selected only 3 areas. Number 1, branch pulmonary artery. Number 2, ductus arteriosus. And number 3, atrial septal stent, and concentrate only on these 3. Because incidentally, today evening at 7:30, there is a CSI Frankfurt webinar on coarctation. So intentionally, I avoided coarctation because otherwise there will be an overdose of coarctation stenting for all of you. So now coming to branch pulmonary artery. Branch pulmonary artery stenosis is classified as type 1 if it is only one vessel stenosis. So this is only main pulmonary artery stenosis. This is only right pulmonary artery stenosis. This is only left pulmonary artery stenosis. This is type 1. Type 2 is bifurcation stenosis. So end of MPA and origin of RPA and LPA, bifurcation stenosis. Type 3 is multiple peripheral stenosis, multi-level stenosis. 4th is central and peripheral stenosis. Now, let us see. Type 1 stenosis, a regular unilateral right pulmonary artery or left pulmonary artery stenosis is rather very simple. So I'm not going to touch that. Type 2 bifurcation stenosis, let us discuss. Type 3 multiple peripheral stenosis, we will discuss. Obviously, we cannot be doing all this, central plus peripheral stenosis, so I am ignoring that. Having said that, I will ignore type 1 pulmonary stenosis. While right and left pulmonary arteries are easy to stent, main pulmonary artery is going to be tricky. So this is a main pulmonary artery stenosis after arterial switch operation in a 3-year-old child, severe supravalvular pulmonary stenosis. So now if you carefully see here, there is a right ventricular outflow tract. This is a post-Lecomte pulmonary artery, and there is a tight supravalvular pulmonary stenosis. And here you may have to use a stent to relieve the main pulmonary artery stenosis. And you need to be careful that you are not trapping the pulmonary valve too badly. So this is a small supravalvular pulmonary stenosis. The pigtail holes are straddling all across because it's a very small child. It's a 3-year-old child. So it looks like there is a significant pulmonary regurgitation. However, basically we were able to protect the pulmonary valve just at the tip of the stent. Coming to distal main pulmonary artery stenosis, if there is a discrete distal main pulmonary artery stenosis, the stent should not protrude too much into the right or into the left. So in this particular area, you may have to use what is called as a double balloon single stent strategy. I'll show you an example. So this is one sheath is passed, two guide wires are passed, one into the right and one into the left. And through that, so this is one into the right and one into the left. Then you advance two balloons with one single stent. Now the stent cannot cross the carina of the pulmonary artery. So the stent will get stuck at the distalmost main pulmonary artery. Once you reach the distalmost end, then you inflate it. There are certain ways of calculating what will be the total effective diameter. If you are taking two 8 millimeter balloons, the effective diameter is 11. If you are taking two 10 millimeter balloons, the effective diameter is 14. 12 millimeter balloon is 17, and two 14 millimeter balloon is effective diameter is 20. So you, based on what size stent that you need here, you have to choose the balloons and you have to mount it. Now here you see that the two balloons are there, the stent has been opened, and exactly the stent is stopping at the, this is the right and the left pulmonary artery. And so it is very important to, you can see here, this is the right, this is the left. We are not encroaching into the confluence. So it is just stopping there. So this is called as double balloon single stent strategy. In bifurcation, there are some other types of stenosis strategies also needed. For example, here, this is a bifurcation, but right and left are also involved. In such a case, so there is distal main pulmonary artery as well as proximal RPA and proximal LPA. This is all common in Taft pulmonary atresia conduit, truncus conduit, Rastelli conduit. So this is, you can appreciate here, there is a tight narrowing of, yeah, you are able to see the still frame here. There is a distal conduit narrowing plus RPA and LPA narrowing. So here what you need is Y stenting. That means two axes, right femoral vein, left femoral vein, two separate sheets, two separate guide wires, two separate balloons, two separate stents. So you are putting in two separate stents. The only thing is we should ensure that both the stents are deployed simultaneously. So these two stents are now protruding in such a way that it is like a double barrel in the conduit and it is protruding into both. Now, sometimes the pulmonary artery narrowing will extend for a long distance. This is also another similar anatomy, but the difference is the left pulmonary artery is long narrowing and right pulmonary artery is also long narrowing. In those cases, the same Y stenting, but with long stents compared to the previous one. Now we have to use a long stent. So this is an example of a long stent that goes almost up to the hilum. So this is a Y stenting. The double barrel is sitting in the main pulmonary artery, and you have the left pulmonary artery going deep inside, right pulmonary artery going deep inside, and this is the original anatomy and the subsequent anatomy. Sometimes there will be complex trifurcations, wherein one of the stenosis will be more severe and one of the stenosis will be less severe. So here you may have to use strategies that are different. So this is a main pulmonary artery continuing as a right, and right is very big, but left is very small. So how will you now tackle it? So you have a strategy where you mount the stent on a balloon and have another balloon protruding through the side strut. So carefully keep watching here. We are pushing in the balloon tip just outside through the side of the stent. You may have to take a sufficiently a larger sized sheath. You see here the wire is exiting through the side. So first you have to place two wires, and on the balloon now you are mounting the stent. Second balloon should exit through the middle, and now through this lumen one of the wire and through this lumen one of the wire. So this is called as two wire single stent side arm strategy. So now you are able to enter inside. The moment you do that, you are deploying the stent. Now the stent is getting deployed across the right pulmonary artery, but you are protecting your path for the left pulmonary artery. And now subsequently, after dilating the primary balloon, the secondary balloon is now getting dilated. You see, the secondary balloon is now opening. And so now you are creating a pathway for both the right and the left. So this sort of stenting is called as T-stenting strategy. There is another way of modified T-stenting. Sometimes there will be multiple level stenosis. This is a post-arterial switch operation, RPA narrowing, LPA narrowing, and main pulmonary artery narrowing. So what we have done here is two separate sheets, right separate, left separate, 2 stents are put. Now there is a main pulmonary artery narrowing. So now you are going into the main pulmonary artery with a single balloon and you are expanding it. And this is the final picture. So there is a T vertical limb and there are horizontal limbs. So this is right, left and a vertical limb. So this is a modified T stenting. The last one is called as culotte stenting. Actually, people who are doing coronary angioplasty and coronary artery stentings will be well averse with all these technology because bifurcation is very common in them. Unfortunately, in pediatrics, we are not so well exposed, and that is the reason why I am drawing a lot of cartoons to explain it. Basically, culotte means a type of a band wherein there is a common orifice and there are 2 exits. So this is if this is the pulmonary artery anatomy with a tight LPA origin narrowing with the main pulmonary artery narrowing, let us see how it is being done. So this is the main pulmonary artery narrowing. This is the LPA narrowing. So we are now positioning the primary stent. So the primary stent is towards the right pulmonary artery. And now you are poking your way through the strut into the left pulmonary artery and then going with another stent through the left pulmonary artery. And finally, that stent is getting deployed. So now you have right pulmonary artery stenting coming into the main pulmonary artery and left pulmonary artery stenting is going through that stent out. So this is what is called culotte stenting. So these are the various ways to attack bifurcation. The third one, post-hilar peripheral stenosis, intrahilar stenosis. So you have stenosis not in the right or left. Right and left I intentionally ignored because this is one that has been done routinely. So post-hilar. So this is an example of a cutis laxa, post-hilar severe stenosis. The main pulmonary artery right, left are good, but severe narrowing distally. So here there is a severe narrowing. Here there is a severe narrowing. So you are going inside and you are positioning your stent into this part. Now we have to be very careful. The moment you dilate the right, immediately there will be a hyperperfusion lung injury on the right and there will be a bronchial bleeding from the right side. Same way, if you are doing left will have hyperperfusion. So you should have something called as double lumen endotracheal tube. You see here this endotracheal tube? This endotracheal tube goes into the left bronchus. So there will be a cuff here for the left bronchus. And there will be another cuff here for the right bronchus. So you can, if I am going to dilate the right, I will close the right bronchus so that there will not be any bleeding. You see, this is now the air is going only into the left bronchus. Now the stent is being positioned across the hilar stenosis, severe hilar stenosis. And now we have expanded it, but the right bronchus is completely closed. So since the right bronchus is closed, the hyperperfusion lung injury that has come will not produce a bleeding. The patient will remain stable till you go into the left pulmonary artery and dilate that also. The moment you dilate both, the main pulmonary artery pressures now come down. Thereafter, there will not be a chance of hyperperfusion lung injury. So double lumen endotracheal tube to selectively collapse one lung or the other may have to be needed. So this is the original anatomy where the right and the left were severely narrowed, and this is the later anatomy where the right was open and the left was open. So basically, you need to strategize. One major question that will come always whenever I am showing so much of metal in the lungs, is it a one-time intervention? You are putting in a metal. What happens to this child later? Obviously, in any growing child, the child will outgrow the stent. And there can be instant intimal ingrowth also. We may have to do multiple redilatation. So we have to put in stents that are redilatable in future. Some of the examples of bare stents that can be de-inflated in future will be Genesis stent, Intra stent. Some of the mounted stents are Formula stent, Valio stent, Andra stent. So these are all the stents that should be used. CP stent, they should be used. We should not be using all the renal stents and the iliac stents, which are non-post dilatable. We also have to understand that there is something called as unzipping of a stent. Unzipping of a stent means you put in a stent that is say 10 millimeter, but when the child grows to about 20 millimeter, 20 kilogram, 20 years or so, you may have to put in a very high pressure balloon and break it longitudinally. That is called unzipping of the stent. And then put a covered stent into that. And similarly, we sometimes may have to re-stent for fractured stents. Whenever you are unzipping a stent, the stent will get fractured and you may have to re-stent. So we should have clear strategies for doing multiple interventions. Unfortunately, the reason why we are forced to do so much of pulmonary artery stenting is pulmonary artery surgery is highly unrewarding. Whatever type of repair that you try to do, for a branch pulmonary artery narrowing, if you are doing a surgery to enlarge the pulmonary artery by either a pericardial patch or a homograft or anything, these pulmonary arteries, they often come back with severe stenosis. So in summary, complex pulmonary artery stenting needs different strategies: double balloon, single stent strategy, Y stenting, T stenting, culotte stenting. Always use post-dilatable stents. Never use a renal stent or a iliac stents. Avoid pulmonary valve inclusion in MPA stents. And we have to counsel the parents for multiple future re-interventions. Now the second lesion, madam, I'm going to talk only about ductus arteriosus and atrial septal stent. If there is any question about pulmonary artery stent, I will just stop it here and then allow some questions and then again come back. Or if you want me to complete, whichever way you want, whatever is your, I can stop here and I can take some questions on pulmonary artery stenting, then go for.
Yeah, that I think that will be nice. I am not seeing any question in the chat box.
Okay,
Actually, this was a very nice deliberation on the complex pulmonary artery stenting. You are very lucky that your surgeons are doing so many cases and you are getting these kind of cases. But for us, you know, our cardiac surgery is not yet that much developed here. Till today, we are sending many of our patient to your country for surgical purpose. And then we don't have that much of the imaging facilities. Till today, we don't have even cardiac MR, and you have rotational angiography, but we don't have. So with all these limitations, we actually can't do that much of the advanced things for our patient. Even then, the type 1 you have not discussed, but type 1 type of the pulmonary the stenting, these are easier and we are doing those things. But about the Y stenting, T stenting, and your cumulative stenting, we have no experience on these things because we are actually not getting these types of patient. So you are very lucky in this regard, because if you don't have any patient, then you will not be able to work on it and to develop your skill. So number of patient and availability of all kind of patient is very important for a pediatric cardiologist. So as we don't have any question here in the chat box, I think you can proceed to the ductal stenting part now. And then if anyone asks any question, I will tell you.
Sure. Actually, you made a very, very important point, madam. In fact, pulmonary artery stent angioplasty is primarily a post-operative intervention. You have a patient who underwent either a tetralogy of Fallot repair or a conduit repair or an arterial switch operation or a Glenn-Fontaine, and in them, when they develop a pulmonary artery narrowing, then you go in and do these interventions, and hence it is primarily a post-operative intervention. So with the evolution of a cardiac surgical and a cardiac program in every country or every city, first you will have the first rise where there will be about lots of cardiac surgeries that are being done.
Yes.
Exactly 10 years later, there will be a huge rise of patients who are now coming with residuals. It's something told like this: if you have tetralogy, lots of tetralogy that you operate in the year 2000 to 2010, you are going to have many pulmonary valve replacements between 2020 to 2030. It's basically like a timed cycle. So you will get all these patients, but the only thing is it depends on when it's like the first wave of corona followed by second wave of corona. You will get the second wave, but it depends on when you get the first wave. If you are late to get the first wave, you will be late to get the second wave. So something like that. Yeah, your point was extremely valid.
Shiva, one thing.
Yes, sir.
All the stents you are putting in the pulmonary artery, they are redilatable stent or single time stent?
Always
Yes.
use a redilatable stent, sir. Actually, the stents, I'll just list out the stents that are being used commonly. In the Cordis, Genesis stent is one of the commonly used stent. Genesis XD, which is a redilatable stent, which is actually a bare stent that you have to mount it on a balloon and then go and put it. There is a pre-mounted Genesis stent, which is not extremely dilatable. I'm not talking about the pre-mounted Genesis. There is a Genesis XD, which comes as 1910, 2910, 3910. These stents are the ones that can be dilated. The second group of stent is called intrastent, which is coming from the EV3. EV3 is now taken over by the Medtronic. So intrastent max and intrastent mega. These are stents that can be dilated to 18 millimeter and 25 millimeter. What is easily available now in India is Andra stent. Andra stent is a stent that is available as large, extra large, and double extra large. It can go to 18, 25, and 32 millimeters. CP stent, we all have. CP stent can go up to 22 to 24 millimeter. And then we have some other stents also that are now coming up called as B graft, which is coming more and more in the eastern part of the country. You will find a lot of Malaysian doctors, Thailand doctors, Vietnamese doctors, and all using a lot of B stents, which is again dilatable up to 18 to 25 millimeter, depending on whether it is M or L. And so these are the varieties of stents. Some of the pre-mounted easily deployable stents are the Formula and the Valio. Cook Formula is available up to 10 millimeter. And if you are putting in a 8 millimeter stent, that can be dilated to 16 millimeter later. Similarly, Valio 8 millimeter can be dilated to 16 millimeter. So almost always we will be using a post-dilatable stent in pulmonary artery. In fact, that was what I was telling in the last slide. It should be post-dilatable. We should allow the child to have a later dilatation. Sometimes when we dilate these stents in future, these stents may fracture. And if they fracture, then you should be ready to put in another large stent inside. So it's always should be a redilatable stent.
Yes, Dr. Shiva, I saw one of your patient in some journal, I think. You have some Indian stent.
Yes,
And
recently, it's an extremely good stent, madam. It's called a Zephyr. Zephyr is a stent that is made by a company called Sahajanan Laser, that is from Gujarat. It's from the western part of the country. This stent is made of cobalt chromium. It has been made with a selective engineering design that there is no foreshortening. So it's available. These stents can be dilated up to 18 millimeter. And these are available as 18, 28, 38, 48, 58. If you have a 18 millimeter stent and you dilate it up to 18 millimeter, there will not be a foreshortening at all. So it's a very, very useful stent. Unfortunately, the marketing strategy of these people are very small. So they are not able to penetrate a lot into the Indian market, but it is much cheaper compared to Andra stent. Andra stent is a German stent. It's almost about 60% of the cost. Definitely, it is a very, very useful stent, madam. We published our initial literature in catheterization and cardiovascular intervention, and it's a very useful stent.
We already requested for this Zephyr stent. We are communicating with one of. What about Advanta? In your experience, you have not mentioned about Advanta.
Yeah, Advanta has been withdrawn by the. Actually, Advanta was previously with a company called Atrium, and then the Atrium was bought over by Mackay, another company, and then Mackay itself stopped the production. But now in America, they have got a selected this distribution. They have renamed it as ICAST, ICAST, ICAST. This particular stent is now available only in the small sizes up to 10 millimeter. Previously, we used to have 12, 14, and 16 Advanta V12. Now the 12, 14, and 16 has not been given an FDA approval. So they have not started manufacturing it. It's available in USA as ICAST only up to 10 millimeter. The original Atrium is no longer there. That company has been bought over by 2 different companies. So now it's no longer available. There are some advantages of that particular stent, that it is a very good covered stent.
We have actually a good supply.
You still
Yeah.
have supply, madam?
Yes, yes, we are using it in most of our coaptation, and they are also redilatable. Good thing is that these are covered stand, redilatable. And we have here up to 14-16 millimeter diameter is available.
Yeah, it is.
And still we have supply. Maybe this is the old supply. Recently we have not ordered, but
Yeah,
we have still some Advanta in our shelf.
Sure, sure. Actually, Advanta,
Okay, Dr. Shiva, you can carry on.
yeah, Advanta V12 is available as 12, 14, and 16 millimeters, and they are capable of dilatability up to 22 millimeter maximum. It's a double-layered
Yes.
PTFE cover on either side. Now coming to the
Yes.
ductus arteriosus, stenting. Assuming that you all routinely do, I'm going to just focus on 10 tips. Now, the study the anatomy of the ductus carefully on echocardiogram. I stress on echocardiogram. Even though some of the centers publish data like based on CT, they plan how to go ahead, how to do the procedure, what is the length. Practical problems are, number one, an additional radiation for a small baby. Number two, we have to transport the child to transport the newborn to a CT machine. And we have to maintain a sedation during a CT. And we have to give a contrast dose which may be tolerated or may not be tolerated. And sometimes we will not be able to precisely time the bolus. So by the time the bolus reaches, the picture will, by the time the picture is taken, the bolus would not have reached the heart. So, but you will find that in the literature, there are CT images. Primarily, I would suggest we should try to concentrate. This is a chapter that I have written on the Buteras textbook on ductal stenting. We should primarily concentrate on the echocardiogram. A suprasternal view, seeing how tortuous it is, what is the total length of the ductus, what are the points of the narrowest place in the ductus arteriosus, and to which neck vessel is it closer, how to plan an entry into the ductus. So first thing is concentrate on the echocardiography. In echocardiography, the warning bells are, if it is a vertical duct or a tortuous duct, or if there is a confluent stenosis, or if completely there are two separate pulmonary arteries with two separate ductus, non-confluent pulmonary artery, or hypoplastic pulmonary artery, or if there is a poor ventricular function or severe AV valve regurgitation, this child is going to be very high risk procedure. The second one is we have to decide on the access, how we are going to do. If it is the duct is from the usual place, that is type 1 ductus, or if it is a contralateral duct means if you are having a right aortic arch and the ductus is arising from the left innominate artery, it's called contralateral duct. If you are having a left aortic arch and the duct is arising from the right innominate artery, it's contralateral. Or similarly, type 5, that is bilateral separate non-confluent duct. These are cannulated better from the femoral artery. But if you have a vertical or tortuous PDA, it is be challenging, and sometimes axillary or carotid access are used. Now, why axillary access? People say not only for the sake of easy accessibility of the vessel, one more point that they talk about is the femoral artery in a small baby when you are cannulating, they are likely to go into femoral artery occlusions. So this is a baby who had a neonatal ductal stenting and the check angiogram is being done. And now you are finding that the left femoral artery, which was used during the neonatal procedure, is now clotted up. So since the pulse loss is very high on femoral artery, people started advocating axillary may be a better option. But we need to remember, axillary artery is also prone for a similar narrowing. But the only difference is this is a post-ductal stenting using an axillary access. Again, a check angiogram during the next cardiac surgery. This also will get narrowed, but because of the anastomosis around the scapula, clinically it will be very difficult to identify axillary artery occlusion, whereas it is easy to identify a femoral artery occlusion. Having said that, limb growth in both are equally bad. Here the hand will grow poorly, there the leg will grow poorly. Issues about carotid access. People have started talking about carotid access also, but we need to remember that rare patients can get thrombosis of the carotid artery and there can be tiny amount of residual stenosis of the carotid artery. So we need to be careful whenever you are using an unconventional access. The third one is how will you cannulate? After you decide on the access, then you enter and how will you cannulate? If it is a straight ductus, it's a simple cannulation. You are just using your right coronary artery catheter and you are pushing in a guide wire. Similar thing is in the contralateral ductus also. So this is a contralateral duct that is left, it's a right aortic arch with a left innominate artery, and left innominate artery is giving the ductus. So in both these cases, your routine femoral artery cannulation is going to be very easy. But if it is a vertical or tortuous duct, you may have to use, if you are using the femoral catheter, the cut pigtail. So the cut pigtail hooks into the ductus arteriosus, and now you are using progressive advancing of a floppy guide wire. And the moment the floppy guide wire advances a little bit more into the main pulmonary artery, then you will have a straightening of the course. Sometimes, if one wire is having an extremely tortuous course, advance a second guide wire. The second guide wire will now help in positioning the stent, because this is called as a buddy wire. The second guide wire will allow positioning of a stent in a very tortuous lesion. The third, sometimes if suppose the wiring is extremely, now you keep watching this, the guide wire is slowly progressing inside, and the moment the guide wire reaches a sufficient amount of length, then there will be some amount of straightening of the ductus. But if you continue to observe a curve on the straightened portion of the ductus, then you always use a double wire. So this is a second buddy wire, and the second buddy wire is in place. Now you are taking the stent. The stent, when it is going, withdraw the guide wire so that there is no redundant lumen at all. So this is the guide, the stent has now reached the ductus arteriosus, and then subsequently the buddy wire should be removed. Sometimes microcatheters will help. So this is another vertical tortuous duct. So here the guide wire is going in, and this is a microcatheter, a fine cross microcatheter or a coarser microcatheter. This microcatheter itself will now cross. You now see that the guide wire is slightly entering in. So now the microcatheter keep pushing it in, and at one particular point, the microcatheter will jump on its way, because microcatheter has got a tendency to straighten out. So now the microcatheter has gone inside, and once this goes inside, then subsequently advance the guide wire and get into a stable position. So catheters like fine cross or corsair, which are microcatheters, can be useful. Some of the vertical tortuous ductus can be dealt with by transvenous stenting. So this is going from the right ventricle through the VSD into the ascending aorta, and transvenous you are going and stenting the duct. So this is also another useful strategy in a vertical ductus. Very rarely you may have to use axillary artery access. So this is a very tortuous duct. I'll just freeze it when the ductus is sealed. It's so tortuous that it is not going to be possible. You can now appreciate it. It goes up and then comes down. So this amount of tortuosity, it will be very difficult to manipulate with the femoral catheter. Even with an axillary catheter, it is so tortuous. So here what we are doing is, we are advancing a microcatheter. You see this black dot, this is a microcatheter that has gone in. And once you have a microcatheter, then through the microcatheter advance a very stiff guide wire. This is Iron Man guide wire. So once you advance a very stiff guide wire, the stiff guide wire will completely open out the entire tortuosity. So now the entire tortuosity is gone, and the stent can be deployed. One of the doubts that often happens is, what is the length of the stent that is needed? If you have such a doubt, you take one empty balloon, pass that empty balloon across the ductus. So this empty balloon has got 15 millimeter marker. There are various empty balloons. Like you take, for example, a 2 millimeter into 20 millimeter balloon, then 20 millimeter will be the markers. 30 millimeter means 30 millimeter will be the marker. So take balloon with 2 markers, push it inside, then inject. Now you see a rough length of what is the length of the ductus in comparison to the length of the marker. So this is one of the way of identifying the length. Sometimes there will be tight confluence stenosis. So there is a severe confluence stenosis both in the left and both in the right. So here definitely, if you go into right, left will be pinched off. If you go into left, right will be pinched off. So you have a double stent strategy. So through the femoral way artery, you are putting it into the right. Through the axillary artery, you are putting into left. So there are 2 stents, and both the stents are simultaneously deployed. So this is right stent and left stent. And here, this is the final stent position. So this is like a Y stenting, and you are able to get a good perfusion of both the lungs. And then subsequently, during the final surgery, the surgeon will take out the entire area and repair the confluence. The next tip is neonatal ductus are very friable with a lot of mesangial cushions. This is a neonatal ductus. Now the ductus has closed off. It's a 3-day-old ductus, and when you pass a guide wire, the guide wire is actually dissecting the whole of the ductus. We need to be very careful, and you have to use extremely floppy wires. So through this dissection, now you are passing a floppy wire, and subsequently you are able to get the catheter inside. You are seeing the stenting here. So floppy and intermediate wires should be used, and you should not use a chronic total occlusion stiff wires. The wires like Pilot, wires like Fielder XT, Conquest Pro, all should not be used in a ductus arteriosus. The final word, no PDA should be taken lightly. Every PDA stenting can turn into a nightmare. So this is a patient who is 3-day-old. Prostaglandin was just stopped 30 minutes before. The ductus has closed. And now looking at the ampulla, we felt that it is very easy to cross this ductus. And when we are advancing the floppy guide wire, the guide wire is actually going into the pericardium. So we need to be very careful. We cannot take it for granted that a freshly closed ductus after prostaglandin withdrawal is going to be easily be allowing. It can allow anything, and the guide wire can go into the pericardium also. So we need to be careful. Then tip number 8, bilateral ductus, non-confluent pulmonary artery. So this is a ductus which is right duct is arising from the innominate artery, left duct is arising from the undersurface of the aorta. So first you are targeting the undersurface of aorta and stenting the left pulmonary artery, and then you are taking the catheter into the right, and this is right separately stented. So in these sort of stents, you have to use a smaller stent like 3 or 3.5. Otherwise, the lungs will get flooded and the patient will develop heart failure. Last, prostaglandin should be discontinued neither too early nor too late. If you are stopping too early, the ductus will go into severe spasm and then you will not be able to cross. If you are taking too late, then the stent can embolize. See, this is a ductal stent that is being placed. The stent has been placed properly, but now when you are injecting the contrast to check the ductal stent, the stent is actually getting pushed into the main pulmonary artery. It is stent has got embolized into the main pulmonary artery, and now you are having still the wire. And as you are watching, the stent has now gone into this limb. So this is the ductal wire. It has turned in the main pulmonary artery, and it has gone into the main pulmonary artery's undersurface. And as you are trying to capture it with the balloon, it has gone almost into the right pulmonary artery. So this is the balloon that has trapped that stent, and you are pulling it back in order to bring it back into the ductus arteriosus. Now you see that it's being brought back, and as you are bringing it back, have indomethacin to be injected through the side arm of the sheath so that the ductus is already primed for closure, and then you close it. So stopping prostaglandin too early to prevent it is also hazardous. So this is a prostaglandin that has been stopped too early, and now what is happening? When you are puncturing the axillary artery and getting in, the ductus is completely closed. So then you try to put in a microcatheter there. There is no flow at all, and through that somehow you manipulate and get the wire into the left pulmonary artery, and now you are able to close it. The last thing in extremely low birth weight babies, if you are going for a femoral artery, definitely the patient may lose the pulse, and hence this is a transvenous approach. So this is an RA, RV through the VSD into the ascending aorta, and then you turn the catheter towards the descending artery, and this is a tortuous ductus, and you wire it from the venous catheter and you stent it from the venous catheter. So this is it's a transvenous stenting. So very, very small babies where you feel like there is a strong chance of losing the femoral pulse. So this is a 4 French femoral sheath, but for a ductal stenting, if you have to upsize, then we may be losing the femoral pulse. So these are some of the things. So ductal stenting is another challenging procedure. Carefully assess the patient by echocardiography. I am not a strong advocate of CT scanning for every newborn because that gives additional radiation. Stop prostaglandin well in advance. Use soft tip guide wires, buddy wires, microcatheters, and appropriate stents. Drug-eluting stents are safe. We have actually published our data in the pediatric cardiology. If you are using drug-eluting stents in small newborn babies up to 22 millimeters, it's reasonably safe. Never underestimate the procedure. Surgical standby is crucial, and axillary and carotid access will help you But remember that they also have issues. Axillary pulse loss and carotid thrombosis may happen. As a continuation, I'll just briefly touch on RVOT stenting because this is very related procedure. It's done in tetralogy of Fallot with PA hypoplasia or very critical pulmonary stenosis. Post perforation of pulmonary atresia, intact ventricular septum where there is a tight annular narrowing. Adults with tetralogy with severe polycythemia coagulopathy, in order to temporarily palliate them so that the polycythemia will reduce and these patients will become fit for the surgery. Whenever there is a delay in the corrective surgery, post-balloon pulmonary valvotomy for a dysplastic Noonan syndrome and extremely muscle-bound RV, anticipated RV restrictive physiology. I'll show one extreme example of a restrictive RV physiology. This is a muscle-bound right ventricle. This is an apical four-chamber view. It's a totally muscle. This is the RV cavity. This complete thing is RV muscle, and this is the squashed LV. Right atrium is hugely dilated with the coronary sinus. Atrial septum is bowing. So this was a severe pulmonary stenosis in the Noonan syndrome. So when you put in the catheter into the right ventricle, there is a tight annular stenosis here. This right ventricle is like a rock, and the right ventricular pressure is 180 to 190 against an aortic pressure of about 100. Suprasystemic RV pressures. That right ventricle is not looking very optimistic for a surgical transannular patch because this patient will have a severe RV restrictive physiology. So you put in a stent. Now after the stent, the RV pressure now comes down to just 40 compared to aortic pressure of 170. So there is complete reversal of the two pressures. Now what happens to the echocardiogram? This is the original echocardiogram that we saw, highly muscle bound. So here also muscle bound, but it is squeezing. It's able to contract. Now with time, there is a possibility that this right ventricle can become slowly better and better now because we have reduced the pressures from 160 to 40 millimeters of mercury. So now we are at the end of ductal and RVOT stenting, which is done specifically for tiny babies with tetralogy-like lesions. And I primarily was concentrating on the tips for people who have already started seeing it. And the last lesion will be atrial septal stenting. Again, I will now just give a break of 2 minutes so that if there are any questions, and then subsequently with atrial septal stenting, I'm stopping. For people who are not aware, there is a coarctation stenting seminar today in CSI Frankfurt at 7:30. So please, all of you attend. In fact, that is the reason why I am avoiding aortic coarctation.
Okay, Dr. Shiva, there are some questions in the QA box.
Yes, madam.
Dr. Surabhi Das,
Yes.
she asked how to decide the diameter and length of the main pulmonary artery in T-type stenting.
Okay. In main pulmonary artery should basically whenever there is a complex pulmonary artery intervention, it is better to have a three-dimensional imaging. I would prefer a CT pulmonary angiography. The moment you have a CT pulmonary angiography, it becomes very easy to identify what is the length of the main pulmonary artery, what is the diameter, and what is your reference diameter. Let's assume that it is a post-Lecomte main pulmonary artery stenosis in an arterial switch. Our target will be at least the stent should be as large as the pulmonary annulus, because pulmonary annulus will be normal. So target, the diameter should be something equal to the pulmonary annulus, and the length should be covering the entire main pulmonary artery stenosis without touching the sinotubular junction. So you will be able to make this decision based on a CT pulmonary angiography. Now, after doing that, if you don't have an appropriate length of the stent in your shelf, that comes the question. Fortunately, certain types of stents are easy to cut. If you have the Cardis Genesis stent, it is the most easy stent to cut. In general, stainless steel stents are easy to cut. Cobalt chromium is a little difficult, and platinum iridium is very difficult. So how you have to cut it is, you just take a straight, hard, big scissor and just cut out the stent, whatever you don't need. Let's assume that I need a stent that is only about, say, 18 millimeter that I need. But the stent that I have is 3910, which means 39 millimeter long. Take the stent, cut it at the middle so that you are having 19 millimeter. And the crushed portion, the portion that you have cut will be very irregular. Ensure that that portion is mounted proximally. So when you are mounting it on the balloon, you have to mount the good part of the stent distally and the rough part proximally, so that the stent will not get hitched against any irregular parts and then evert out. So you can choose the stent, you can cut a stent. The other stent that can be cut is Andra stent can be cut. The Indian Zephyr stent can be cut. You have to use heavy scissors.
Okay, so this is the answer of the first one. Now, anonymous attendee,
Yes.
no name. Do you need special cath lab to perform a rotational image of PDA? If not, please tell how do you perform? Again, do you perform VQ scan before stenting peripheral branch pulmonary arteries?
Okay, the first one is a cath lab. The cath lab should have a rotational angiography facility. So nowadays majority of the cath labs have got a rotational angiography facility, but you have to check with your cath lab technician whether your machine can take a rotational angiography. The basic principle of a rotational angiography is the machine will rotate from right lateral to left lateral 210 degrees in a Philips machine and 180 degrees in a GE machine. The rotation will be 4 seconds to 4.5 seconds. And in this 4.5 seconds, there will be a continuous injection of the contrast from the injector into the target zone. Since the contrast dose will be higher, very often it is diluted to 2:1 dilution. That means 2 times contrast and 1 time saline. And you need to plan out the injection, the volume. For example, let's say a 10 kilo child who is having a pulmonary artery bifurcation stenosis. A 10 kilo child will probably need 30 ml of contrast, 15 ml of saline. So dissolved together, it is 45 ml. This 45 ml has to go in 4.5 seconds. So it is 10 ml per second. And you have to set the injector at 10 ml per second and inject the entire 45 ml over the whole of the 4.5 seconds. And the machine will go from right lateral to left lateral and occur in all the frames. The moment it is done, it is an automatic 3D reconstruction. The machine will do it. It's available with Philips, it's available with Siemens, it's available with GE. Just check with your cath lab technician. Number 2, about performing VQ scan before stenting of the peripheral pulmonary arteries. Let's divide it into two ways. If there is a bilateral pulmonary artery stenosis, there is no utility of VQ scanning because both will be distributed. The perfusing agent, macroaggregated albumin, will be distributed bizarrely. So if it is a unilateral pulmonary artery, definitely it is of use. And the general rule that is taken is less than 30% perfusion in one of the lung is an indicator for doing a PA stenting. So which means 25% in the affected lung and 75% in the normal lung. So then it is an indicator. So less than 30% on one of the lung is an indicator. But you need to know that this lung perfusion scan can only be done in a patient where there is no right left shunt. If you are injecting contrast technetium labeled macroaggregated albumin in a patient who is cyanotic, who is having right to left shunt, all the macroaggregated albumin will cross over into the brain and go and clog the brain. So you need to, for example, a post-tetralogy repair unilateral RP or LPS stenosis, ideal case, you can do that. But you cannot do it for a Glenn shunt stenosis. If you go and give in a Glenn shunt stenosis VQ scan, the macroaggregated albumin that you are giving will go through all the venous collaterals, enter into the systemic circulation and go into the brain, and the patient will become syncopal. The patient will develop transient hemiparesis, aphasia. So you need to be careful in choosing the patient. Post-surgical correction, post-total surgical correction of tetralogy or post-total surgical correction conduit surgeries where there is no residual right to left shunt and there is an unilateral PA stenosis, then you use a perfusion scan. Perfusion scan is done with technetium labeled macroaggregated albumin. There is no need to use a ventilation scan and all. Nobody uses ventilation scan because we are assuming lungs are always normal. So there is no need to match it. Ventilation scan is only done when you have patches on the lungs and you have to differentiate between pulmonary embolism versus segmental lung pathology. So here Practically, it is perfusion imaging with technetium labeled macroaggregated albumin injected in one of the cubital arm veins.
Okay, thank you. Then another question from Dr. Shoma Kasturi.
Yeah.
Sir, can you let us know the branch pulmonary artery flows in follow-up?
Yeah, so the ways in which you can track the branch pulmonary artery is one of the simpler way is just the lumen of the stent. If your stent is say 8 or 9 millimeter, then that means your vessel is 8 or 9 millimeters. If over a period of time, if you want to follow them up, you can use CT scan. You can use conventional angiography. CT scan will show whether there is an intimal ingrowth and fractures. Conventional angiography, you'll be able to post dilate. Echocardiography is a little tougher method of assessing and unilateral PH stenosis after stenting. It's tough to interrogate because echocardiographic signals, Doppler signals may not sufficiently be reflected in a stented pulmonary artery with all the metallic artifacts. Often you may have to resort to a more advanced 3D imaging like a CT. The second issue is if you have a patient who previously had a perfusion scan difference of say 20:80, now you repeat a perfusion scan after the stent angioplasty, maybe 6 months later, 1 year later, and see how much is the improvement. That is one of the ways of identifying, following up a branch pulmonary artery stents.
Okay, another
We
question.
have only monoplane, madam. We don't have a biplane.
Oh, you don't have.
Yeah, we
Okay.
don't have. We don't have.
Okay,
Actually,
you have rotational and 3D reconstruction.
Yes.
Every facility is available, but I thought that your lab is biplane.
No.
Okay.
Actually, there are certain good things about biplane. Biplane will reduce the contrast dose. In a single contrast,
Yes,
you can
yes.
get 2 pictures. But we need to remember biplane is double radiation. Number 1. Number 2, biplane occupies more space in the cath lab. So if you have more space, more imaging tools will be difficult to enter. For example, if you have a biplane angiography and you want to simultaneously do an echocardiography also, you want to ventilate the patient also, you want to keep the ventilatory machine also next to the patient,
Yes,
you
yes.
want to have a pulse oximeter also, it's all going to be very difficult because biplane will be another monster. So there are definite advantages. Contrast will be avoided. Like you need not take one AP view and one lateral view. In one shot it is done, but double the dose of radiation. So over a period of time, all the low middle income country doctors or the resource restricted country doctors like all of us, we have realized that with a single plane itself, you start off like imagine what is the other plane. Like basically, with your experience, you will know this is the plane at which I will be getting the maximum anatomical information, and you will start shooting at that particular plane. So with experience, slowly we all will evolve out, wherein with 1 or 2 injections itself, we will be able to get the maximum information. But it is a common practice in the Western world to have a biplane angiography as a routine.
Yeah, Dr. Shiva, in our cath lab, we have actually 3 machines. 2 are monoplane and 1 is biplane.
Excellent.
So whenever we feel that this biplane is now important for this patient, then we do in biplane lab. If we feel that no monoplane or where the ventilatory support is required, in that case we choose the monoplane. Anyways, nowadays machine moves so fast. Within few seconds they change their position. So it's not actually that important whether you have monoplane or biplane, because monoplane can move to the position whatever you want within a very short time.
Yeah.
One of the question, not like question, like opinion, Dr. Tawfiq Shahriar, he is saying that we lack the availability of appropriate stent. I'm answering Dr. Tawfiq's question because he is asking this in actually background of our country. Dr. Tawfiq, actually, if you need any stent, as our market is very small, and this is not like coronary stent that hundreds of doctors are doing coronary stent and everything is available in the country. For our kind of stents, like we need large stent, extra large stent, medium stent, then small stent for the PDA. PDA stent we are using coronary, so you'll find all kind of stent. But for the other things, you have to order those from before. So if you want to do a pulmonary valve, you have to have all kind of stent in your hand, because you don't know whether you will need a pulmonary artery stent at the same time or a branch pulmonary artery, because these kind of patients are associated with some complex situation. So what we do in our hospital, we have supply of all the things. In every year we give demand. So you have to do like this. Unless you order, company will not bring, because date will expire after some time and they will be in loss if you don't use. That's why the company, they don't make it available, because market is very small, only few people are doing and they are actually facing loss. That's why. And another question, or no, I don't think there is no more. About PDA, Dr. Shiva, about the PDA stenting. Many people are doing PDA stenting nowadays here. Most important thing, what they face in the cath lab is engaging the doctors. So just tell them what kind of catheter or what kind of technique is good for the like vertical one, for the other anatomies. And another thing is that the delivery system, you are using 4 French delivery system, which is not usually available in our country. So what we do, we usually use like right coronary guide catheter. So if you can highlight on these points, that what kind of alternative techniques can be used for delivery of the stent, and how to engage abnormal type of ductus, what catheter will be good for which type.
Okay, I'm just showing the different types of anatomy. Is my slide visible, madam?
Yes, no problem.
Okay. So in about say 20% of the patients, for example, critical valvular pulmonary stenosis or pulmonary atresia intact ventricular septum with PDA, where you want to do a stenting, or transposition of great arteries where you want to do a ductal stenting for improving a regressed left ventricle, the pulmonary artery, the ductus will be like this, the usual ductus. In this particular case, a Judkins right coronary artery catheter, we hook the right coronary artery catheter and advance a coronary wire. It is pretty simple. And the moment the coronary guide wire goes deep inside, then we will exchange it into a 4 French Cook Boston Children's Hospital modification of the Cook sheath. Suppose if we don't have, then a 5 French sheath with the 5 French guiding catheter is also another option. The problem will come in these two, the vertical duct and tortuous duct. Both are coming off from the undersurface of the aortic arch. My preferred practice is I use a pigtail first to do an angiogram in the lateral view. Once I do in the lateral view and identify that there is a ductus, let me try to just a second. Now, let us assume that I have a pigtail like this. Are you able to see my
Yes.
picture, madam?
Yes, your drawing is visible.
Okay, so now this is the pigtail and I have done the angiogram. Now, if I have to hook this ductus, I visually calculate at what point I have to break this pigtail. Now I cut this pigtail at this point. So now when I bring this pigtail, the second time the pigtail will be, sorry, actually I'm not able to draw super, but I hope you are able to understand. So this cut pigtail, so where I am going to cut, sometimes I will be cutting here, sometimes I will be cutting here. So for example, this particular pigtail, how I will cut it here. If let us assume that I have a, okay, let me draw another ductus here. So this is the ductus in the third patient. Now what I will do is, I will not cut the pigtail at all, almost like this. So bring down the pigtail and make it hook like this. Like this. So that the place where I'm going to cut the pigtail will depend on how close it is to the descending aorta or how far it is from the descending aorta. If it is too far from the descending aorta, then I will retain more and more of the J. And if I am very close to the descending aorta, then I'll shorten the J. So cut pigtail, hook it, and then advance the coronary guide wire. So this is the catheter that I try to use. The sheath, I prefer a 4 French Cook's Boston Children's Hospital modification. It's called BCH modification or CHB modification, Children's Hospital Boston modification. And that is preferred sheath, but you can use 5 French guide catheter also. So basically it is like cutting the pigtail at a particular area after you visualize where it is arising. If it is a very proximal duct, then I will cut like this. If it is a ductus that is arising more proximally, I will cut here. If it is arising more closer to the descending aorta, I will cut like this. Is this picture clear, madam? Here.
Yes, yes. I think we are doing like this in our hospital. I think the people who are doing in other hospital, they will be benefited from this figure you have drawn here. Thank you. And another question is in the question answer box is, what are the possibly, I'm not seeing that question, possibly I'm trying to see that. Possibly the question is, what are the indication of covered stent or bare metal stent like question? And another question, oh yeah, this is the last question.
Yeah.
Indication of covered stent.
Yeah, actually, because of the time, I took away that covered stent slide. It was there. And okay, basically, whenever there is a fear of rupture of a blood vessel due to a dilatation more than 3.5 times, which means, let's assume the coarctation is about 4 millimeter and you are going to be dilating it to more than 3.5 times, more than 12 to 14 millimeter, then you have to use a covered stent. Number one. Number two, an adult with coarctation and an adult with calcified blood vessel, you have to use a covered stent. In general, if you have a covered stent, it is a safer strategy. Number four will be if there is any side arm vessel that you need to close off. The most typical side arm vessel will be ductus arteriosus. And so if you want to close a ductus arteriosus in association with a coarctation, then you have to use a covered stenting. The other reasons for covered stents are, for example, if you are doing a transcatheter pot shunt, if you are creating a Fontan fenestration and you are perforating from the pulmonary artery into the atrium and creating a Fontan fenestration, in such areas where there is a risk of extravasation of the blood, then you may have to use a covered stent. There are various reasons in the inferior vena cava, Abernethy malformations, you may have to use covered stents. So it depends on a lot of lesion specific approach indications for a covered stent. I took out the slide because I thought it is too long, and so I was editing a lot today, just a few minutes ago.
Today's lecture is actually very interesting because I think future of pediatric cardiology will be everybody will go on with stenting, because there are a lot of things to be done with various kind of stents, not only in the vessels, as you have mentioned, to enlarge various holes like ASD. Even we have placed stent in VSD also to enlarge the VSD. In tricuspid, there was very small VSD and that VSD in few cases also.
Yeah.
So there is a role of stent in future, and days will be very good for those who are good in stenting.
One of the recent reasons for me to use a covered stent in my cath lab in the last 2 years is sinus venosus ASD, which we have now we started using covered stents, which we published in Circulation Intervention recently. I'll come to the last part, atrial septal stenting. Why do we need an atrial septal stenting? If we have to have an intracirculatory mixing between the atria, like a transposition physiology TG or Taussig vein, if you want to reduce the pulmonary venous hypertension when the patient is having a hypoplastic left heart syndrome or a congenital mitral stenosis, so any condition that causes a left ventricular inflow obstruction and where there is a severe pulmonary venous hypertension, the same thing will apply to grown-up patients with diastolic heart failure, a form of restrictive cardiomyopathy or a hypertrophic cardiomyopathy with recurrent flash pulmonary edema, severe pulmonary venous hypertension. patient who is on ECMO with severe left ventricular failure and mitral regurgitation. So in many of the patients, you may have to relieve the pulmonary venous hypertension by decompressing the atria. The third is to improve the cardiac output. Whenever you have a restrictive PFO in a TAPVC or tricuspid atresia or a critical RVOT obstruction, idiopathic pulmonary hypertension, in order to promote right to left blood flow, right atrium to left atrium, and maintain the cardiac output. The methods, what are the alternatives to stenting? You can do balloon septostomy, Z5 balloon septostomy, which is over the wire balloon, static balloon dilatation, broken burrow septoplasty, blade atrial septostomy, and why atrial septal stenting. The advantage compared to all the other methods, atrial septal stenting is a predictable orifice diameter. If I want 8 millimeter, I can clearly give 8 millimeter. Balloon septostomy, you can't dictate that. Balloon septostomy may go to 3 millimeter, may go to 10 millimeter also. So you can titrate the exact amount of communication that you want by using a stenting. The second, this is the only method that works in very thick septum. If you have a thick septum, you can't do balloon septostomy, static balloon dilatation, nothing will work. And the third one, the longevity of palliation is the maximum with this. It doesn't close spontaneously. All the other methods may close spontaneously. Idiopathic pulmonary hypertension, you do a balloon septostomy, sometimes 6 months later, the hole will close. The patient will again develop syncope. And it is the best and reliable strategy in conditions where pulmonary venous hypertension is deleterious. A single ventricle patient with severe mitral stenosis, and you want the patient to live till the Glen shunt, then you have to have a very reliable method of atrial decompression. What are the methods of doing it? I'll tell what is a routine technique, what is a partial unsheathing technique, and what is a diabolo technique. So routine stenting, whenever there is all these are applicable to very small children only. So whenever you are going and to do a transeptal puncture, we remember that the transeptal puncture needles curves are all more for a grown-up heart. So when you are puncturing in a newborn baby, you will not be able to see the curvature. Only the last 2 centimeters of the needle is seen here because the child is so small. So the moment you puncture, you are not sure whether you will pop through the roof of the atria and go out of the heart. So you should have a 1/4 guide wire readily, and the moment you enter into the left atrium, advance the 1/4 wire, lot of the wire into the left atrium, and then you keep on pushing, you will be safer. This, remember, always use a 1/4 wire the moment you enter into the left atrium so that you don't poke through the other wall of the atria. The moment after you put in the sheath, then this is a 1-year-old child, an univentricular heart with severe mitral stenosis, severe pulmonary venous hypertension. Saturations were very low due to severe PVH. So here we have put in the sheath, and through that now we have taken a guide wire. This guide wire was not even able to enter into the pulmonary veins because all the structures were very small. So you just coil out it within the atria, and then you position the stent, you withdraw the sheath, and the stent is positioned, and then the stent is deployed. This is the final stenting. So here you are able to see the distal part of the stent getting open. This is the atrial septum, and slowly you are dilating. So this is the routine method. The problem is you have to have a very careful positioning of the stent. The stent needs to be guided by echocardiography, and you have to choose a stent length which is sufficiently longer so that you don't end up in the entire stent being in the LA or in the right atrium. And very small stents can embolize, and very large stents can poke into the pulmonary vein. So we need to be careful. So this is a 8-day-old baby with a hypoplastic left heart syndrome. So we have entered through the patent foramen ovale, and see here, this is the mitral atresia. There is no mitral exit into the ventricle. All the blood is now coming through the ASD, through the into the right ventricle. And your intention is to relieve the pulmonary venous hypertension because the child is extremely hypoxic. And so what we are doing here is advancing the guide wire, and this is a 10 millimeter stent, and this 10 millimeter stent is expanded. Now you carefully see here, it is such a small left atrium. So, but you are safe from the pulmonary veins. So this stent has been deployed in such a way that it is in the right atrium, it is in the left atrium, it is decompressing the left atrium. There is no mitral valve here, mitral atresia, and you have given a decompression for the left atrium. The second technique that is called as partial unsheathing technique. So this is an adult with post-ASD surgical closure. You can see the wires. Patient is having severe pulmonary hypertension and now getting recurrent syncopal episodes. So here, 50% of the stent is now exposed in the left atrium. You see that the sheath is being brought back. Now you open the stent. So the stent is open. 50% of the stent is open. 50% is still inside. Now you drag the stent all the way down up to the atrial septum. So now you see that we are bringing it down till it touches the atrial septum. The moment you start having a resistance of the atrial septum, that means this portion, this is the atrial septum. So then you unsheath the proximal part. So this is called as a partial unsheathing technique. The moment you unsheath the proximal part, now you have expanded it. 50% is on the right atrium, 50% is on the left atrium. And now when you are injecting the contrast, the dye is able to go from the RA to the LA. So you have created an atrial septal communication again for this patient who had previously an ASD and the surgery has closed the ASD. So the advantage of this is the stenting precision is far more better. So 50% of the stent is exposed, then you open it and then pull back till you reach the atrial septum. The third method is called as diabolostenting. Diabolostenting I'll show the pictures. So this is a situs inversus dextrocardia with a transposition and a mitral valve, which is very hypoplastic, so very high pressure left atrium. So this patient needs a pulmonary artery banding and an atrial septectomy. And if you do an atrial septectomy, that has to be on cardiopulmonary bypass. But the patient's pulmonary vascular resistance is so high that you don't want to do a cardiopulmonary bypass. So what you do here, this is the balloon. So around the balloon, I'm just showing you one snare. So take this snare and now put it around the snare. Now you inflate the balloon. So what happens? The balloon is able to expand fully, but at the level of the snare, it is not able to expand. So this is basically the principle. So what you do is, this is the balloon, take a coronary guide wire and tie it around to the desired diameter. Once you dilate to the desired diameter, so this is the balloon, and now you are inflating, you are having a central waist. And the moment this is done, mount the stent on this balloon. So now let us see in real life how it happens. So this is the balloon, the stent is there. This black color is actually the wire knots that we have tied. So now we have entered into the left atrium. Now this is how the balloon is there. And when you are inflating the balloon, the central portion is not going to expand. See, the same thing is happening here. Now we have exposed it. So now when we are opening it, the central portion is not expanding because there is a thread around it. The thread is holding. You are able to see the thread here. So this thread is actually the PTCA wire that has been tied around. So then once the stent balloon is deflated and the balloon is withdrawn, the thread also comes out because the thread is around the balloon. So the thread also comes out. So this is called as diabolostent. So these are the various ways in which this is the same diabolostent dextrocardia patient. So this is the left atrium, hypoplastic mitral valve. So this left atrium has been decompressed now. So the LA blood is now coming into the RA here. This mitral valve is hardly allowing any flow. And the left atrium is now not in hypertension. There is no pulmonary venous hypertension. So, and you can get guidance from the 3D echocardiogram also. So this is a 3D echocardiogram, subzified view, RA, LA, you can see an en-face view. So now, one of the challenges for atrial septal stenting will be in patients where you have put in a device and now you have to, the patient develops severe pulmonary hypertension that you have to perforate and get back again an atrial septal communication. So you go out of the ASD device. Don't try to poke through the ASD device because ASD device will be highly endothelialized and highly fibrosed because there is a fabric also. So you go outside the device and then poke through. And this is the puncture needle has crossed, the sheath has crossed, and here you are using the same strategy, partial unsheathing. So 50% of the stent is opened. Now that 50% you pull it back to the atrial septum and then unsheath the remaining parts. Now you see this is unsheathing. As you unsheath, the right sided also will get dilated and then progressively dilate both so that you have both the left atrial part and the right atrial part inflated and the central part is now in the region of the atrial septum. So summary of the atrial septal stenting, we should know what are the various options for creating an atrial septal communication, balloon septostomy, blade septostomy. We should try to avoid stenting in a thin, floppy, fenestrated septum. The stent will embolize. Use 1/4 wire whenever you are doing a septal puncture to avoid perforating the LA roof. The stent length should be based on mid of right atrium to mid of left atrium. The stent diameter should be proportionate to the child's age and the required cardiac output. So in a small baby of around 2 months, 3 months, a stent of around 10 millimeter will be enough. But in a grown-up patient of around say 5 year or 6 year for a pulmonary venous decompression, you may have to have a stent of around 16 to 18 millimeter. Partial unsheathing is one strategy. Diabolo technique is another strategy. You should always try to use echocardiography, and stent gives predictable, reliable, and durable opening. So the predictable means I want 8 millimeter, definitely it's 8 millimeter. Reliable, definitely it will not fail. If you do a balloon septostomy, you take out the balloon, it may collapse. Durable, you will have an opening today and you will have an opening 6 months later also. So the last slide of the whole talk, conclusion, utility of the stents. As I told you earlier, I did not cover coarctation of aorta because it is an extensive topic and it is going to be discussed today evening at 7:30. Stents are valuable tools in interventional cardiology in children. We should carefully select the type of the stent and we should try to understand all the potential complications. Many repeat surgery can be prevented by appropriate use of stents in different forms of congenital heart disease. Thank you very much.
Thank you, Dr. Shiva. It is indeed a very nice presentation. And I myself have also learned many things from your lecture. And one of the things people say that there is no end of learning. Every day you will learn, every day you will learn. And from your own work, every day when we work by ourselves in our cath lab, we learn many things. And situation usually led us to do something new, and also for saving our patient's life, we sometimes bring some new technologies, some new things. And when we find this, these are very safe and outcome is very good, then these things become routine in later part. So your presentation on pulmonary artery stenting, and then stenting of the atrial septum and stenting of the ductus arteriosus, I think our students, they have learned a lot today, and they have questioned also, and you have answered very nicely, especially about the PDA stent, because among all of this, PDA stenting is the most important because it is a life-saving intervention, and every day many newborn babies are born with severe cyanosis and with many kind of congenital heart diseases where they need PDA stenting as a life-saving intervention. Though surgery is not available for all cases in our country, at least we can do the stenting so that the patient will be stabilized, and later they will be transferred to other place for their surgical correction. But if a patient need a PDA stent and you are unable to do that, then the patient will die. So I asked question to Dr. Shiva Kumar about the technique of catheter he used, and also the sometime our people, they face problem in using their guide catheter because we don't have that much actually fluent supplies of the disposable items and hardwares in our country. So always we have to actually do the off-label use of the things because we don't have all the appropriate things available in our hands. So when we start to do a case, we have to finish that. In that case, sometime we use some other kind of things, like sometime we use PDA delivery system like ADO2. It is a very small 5 French, and then the 4 French. So sometimes we use even ADO2 delivery system or MA4 delivery system for doing some of the stenting in small children. So I would like to request now if there is anybody want to add anything in the comment.
While adding, I am very happy to see some of the people here, Santosh Kumar Saha, Sumaira Nasreen, whom all are very like potentially the future of pediatric cardiology for Dhaka. I'm seeing a lot of young Bangladeshi doctors, and I'm happy to see some of my own fellows in India like Sudipta. So it's a pleasure to have joined your meeting and indirectly getting in touch with some of the people whom I know personally very well.
Yeah, you know, this is a joint collaboration with Narayana Health also. So today you are taking class from our side, from Congenital Heart Disease Foundation. Next week it will be from the Narayana side. So this is a program of total 28 classes, starting from basics to the advanced. So we are now, this is for student of the postgraduate student of the pediatric cardiology. So step by step, they are now going towards the higher technologies. Initially, they have learned the basic things. Now today is one of the advanced type of class of the stenting. And I think they have learned a lot from today because your deliberation was very like fluent. It was easily understandable and understandable. Your videos were very nice. Your photos were very nice. And I think they have learned a lot. So if there is no comment from other people, where is Dr. Salam? Salam bhai, do you want to say anything?
Actually, efficient lecture delivery, world class state of art lecture. And I always enjoyed his lecture. He's a top class legendary author in pediatric cardiology, not only in this subcontinent, also in the world. And we are really proud of him. We are from the same part of the world. And Dr. Shiva belongs to us. So this is my simple comments, and thank you again, Congenital Heart Desk and Narayana Health to continue this academic program. I think we are really benefited, not only the students, with the fellow, with the faculty, we are also highly benefited. And he has given a lot of examples, magnificent example, including some rare cases, including the tips and tricks. So we learned many things from Shiva. So thank you, Shiva. See you again. Thank you, madam. See you again in the next week.
Thank you, Salam bhai. Thank you, Dr. Shiva, for giving your valuable time to our student. And we are looking forward to see you again in any of our class in future. I wish you will agree to take another class, maybe in this 28 classes.
Sure, madam.
Okay, thank you, Shiva. Thank you.
Thank you.
Thanks to everyone for participating in this today's lecture. So we are leaving now, and stay safe, take care of yourself, and follow the rules which our government are telling us to follow. So as Dr. Shiva mentioned already, that vaccines are not giving that much protection. So by taking only vaccine, we are not safe at all. So we have to follow social distancing, wearing mask and other things. So I'll request all of you to be safe, take care of yourself and your family members and your patients. And thank you again. Thanks to everyone. Thanks to Veximco. Thank you, Dr. Rajiv.